Okay, back to where I was. Okay, this is the bit where we start talking about the person who their eating is reasonably straightforward. It's not, there's no starvation at least, but they're still binging. They're still overeating, and they're still using other behaviors in ways that aren't working for them. So here, what we're looking at is usually the more emotional type trigger. There is one other possibility, which I'll talk about with cue exposure, where we're looking at habits. But right now, I'm just going to talk about the way in which emotions can trigger overeating, and they can end up with you binging, being out of control. And in particular, obviously, this is going to be something you tend to see more with people who are overweight or obese because they're not restricting to try to lose weight. So what they're actually doing is just overeating and gaining a lot of weight because they're eating it on top of a normal diet. If you remember, I showed you that energy graph that shows that very representation. So I want to talk about this because um, there are many ways of working with emotions here. I'm going to talk about one we adopted because it works pretty quickly and pretty effectively. Um, if you've got personal preferences about ways of working with emotions, as long as you can get it done in a good time, to stick within the therapy time, then you're not depriving other people of what they need. Remember, in the back of your head, you always need to be thinking not just the person in front of me, but also that long waiting list of people. If I see someone for 40 sessions, but I could see them for 10, then I could have seen four people relatively effectively. So we've always got to think if I don't need to expand the time, then don't. So I'm going to be talking about relatively rapid ways of working with emotion, and also, if you like, layered ways that are about what that individual themselves might need, what emotion to respond to. I'm also not going to get caught up in the trap of that word trauma informed, because trauma, as I said earlier, is something that happens to lots of us. Um, I do remember quite vividly a car crash I had many years ago, but it hasn't affected me. Whereas other people might have had the same effect, and it could have an effect on them in terms of PTSD and the like, or it could end up affecting their eating. We work with the person in front of us, not with the model that we have that we happen to like the best. And that's always really, really important. So, I'm going to talk about ways of working with emotional triggers, and the way that those emotional factors can vary according to the type of experience the person has had. And also, you know, just thinking about how long you've got. I saw a recommendation recently that you should add in EMDR. This is in a paper that I don't think it's seen the light of day yet. But they recommended adding to 40 sessions CBT T an additional 30 to 40 sessions of EMDR. And this again was without clear idea about why, because they didn't have any evidence that the trauma that people had experienced had an effect on them. That's a vast amount of time to dedicate to one person and can lead to the patient becoming quite despairing as things don't shift as well. We want quick outcome so the person can feel positive about it. Right. So what I'm going to talk about now is a bit of a mix of Jeff Young stuff about emotion inhibition and Marshall Linehan's stuff about emotional invalidation. I'm going to pull those two together because they're kind of, it's like core principles that underlie lots of different forms of trauma, lots of different forms of emotional growth, or poor emotional growth. So hopefully these will make sense of the kind of patients you work with, because we find them really helpful. Whether a patient has an overt trauma or not, and sometimes understanding the kind of the core traumas that underpin a lot of others. So, phase 3, we have a person eating reasonably normally, but they're still binging, they're still overeating, they're still harming themselves, whatever it might be. So we do this when it's necessary. In other words, if phase 1 helped the person get their emotions under control, we may not need this bit. And that will apply to a lot of people, but there'll be other people where we definitely do need it. So we get eating straight, to get mood instability out of the way, and we need to make sure the person's weight is actually fairly stable. um, potentially going up because of the person ignoring and adding binges on top. So we talk with our patient about what emotions are for. Now, a key thing in what we're doing here is not treating emotions as being a problem. Emotions are functional in our lives. We all have them, and if they serve a function, which if we ignore it causes problems. So, what do I mean by emotions and motivation and functionality? Emotions are at heart motivators. They tell us about the ways in which we should be behaving that fits that situation. So, for example, if I'm lonely, pick up the phone, talk to somebody. If I'm anxious, resolve the situation. If I'm feeling depressed, get out and do something that makes me feel happier. If I'm feeling angry, get the emotional situation with another person worked out. If I'm feeling guilty, aim not to do the same thing all over again. In short, when we experience an emotion, if we respond to it appropriately, that's a way of communicating with ourselves about what we need to do in the future. In the same way that, if I feel pain in my leg, that's saying to me, don't go around kicking things. That's painful. That's a bad thing. If I ignore the injunction, keep kicking things, then my leg will get worse. I have to learn from that one. So what we need to be clear about is if people can't use their emotional coping strategies, say picking up the phone when they're lonely, they tend to be left with an emotion they can't do anything about. Now, I'm going to take you all the way back to Isaac's work back in the 60s here. One of the key things we know is human beings don't like having their brains switched on full at all times. We tend to run with about 10% of our cortex active at any one time. We then have lots of reserve to solve situations. So when we're under stress, the cortex lights up. We're trying to solve problems. However, if we then don't react in a way that will help to resolve those problems, we're left with what's essentially an unpleasant feeling. High levels of emotional arousal, if we don't do anything about them, become unpleasant. And that's when you start seeing people do things like self-harm, etc. They use behaviors that are impulsive or compulsive to block out the emotional reaction. Now, if you think about this, I'm not just talking about binging, vomiting. This could be applied to alcohol intake. This could be applied to self-harm, compulsive behaviors in OCD, trichotillomania. They've all got an element of this. Let's block out the emotion about them. So what we're looking for is how to avoid the person using those safety behaviors block the emotion in a way that becomes pathological. If the person learns, when I'm upset, if I binge, I feel better in the short term, then I'm more likely to binge again. Part of our job is to help the person learn. But if I don't binge, the negative emotion goes away. So we're looking for what's the easiest way. Sometimes it's easy, sometimes it isn't. But what's the easiest way of helping the person to actually deal with the emotion appropriately, rather than try to deal with it by ignoring it or cutting yourself, or whatever it might be. So again, very similar to how we understand other problems in mental health, and it divides into two. In the kind of patients I'm talking about at the moment, it's more about impulsivity. The person experiences emotion, doesn't like it, blocks it off, they get drunk, they cut themselves, they binge, whatever it might be. And then, of course, the safety behavior becomes a problem. So I binge the safety behavior to cut off my emotion, but I feel lousy a little bit later. So I need another safety behavior then. The compulsive behaviors are more about never letting the emotion get triggered in the first place. This is where things like avoidance come in. I exercise, I starve myself, I check the railings every day. Any of those is a way of distracting ourselves so we don't let the emotion get triggered. So why do we care about emotions so much? This is where I'm coming into martial and territory. If you're familiar with DBT, apologies, the next few minutes will be dead boring, but bear with me for a sec. I'll come back to the Jeff Young stuff shortly. This is something I always want to be able to explain to my patient, because so many of our patients treat emotions as being bad things, things that they shouldn't have, things that they should block out. And what I want to do is make sure that they actually, if I can face the emotion, I can get rid of the problem. If I don't face it, the problem continues. But they've got to understand why they're doing it. They can't just think we think they're being awkward or difficult, because they get enough of that in everyday life. This is where I talk about emotional invalidation. So Marshall Lenehan talks about this notion that some of us grow up in an environment where if we communicate emotion, if we experience emotion, it gets knocked back. So, as per the quote there, if I show my emotion, particularly negative emotion, if I show individual personality style, that's not tolerated. But there's a lot of value attached to the being happy, not giving up, however positive mental attitude, etc. Now that comes out in different kind of patterns. I'll explain those in a moment. But this is something you see underlying a huge number of trauma effects. When you hear about people who've been sexually abused, physically abused, emotionally abused, neglected, the evidence is actually underpinning those. The thing that has a real major effect here is this level of emotional trauma. And that's why we focus on it so much. Now, the emotional invalidation, you commonly see it starting in childhood. That's where it's most common. But you will see it repeated in adult relationships. And sometimes you see people hunting down those kind of relationships. Think about patients you've known where they seem to always pick the dodgy partner. And they pick the dodgy partner not because they particularly want to be hurt, but because they understand the dodgy partner. They've grown up with that kind of thing. So, I understand this. I don't trust the nice guy. Don't trust the nice person. Because they could snatch that away from me. So often you see adult repetition of these patterns of relationship seeking rather, which are about, I know what I'll get into here. I've heard that one way too many times in my life. The nice guy always confuses me, therefore I go for the kind of horrible guy, because I understand that. As I say, commonly starts in childhood, where you've got parental ways of raising you, or schools. I've got a friend who went to boarding school, and when I was describing this to her, she said, that's exactly what happened at my boarding school. That's exactly my boarding school. If I showed any emotion, if it wasn't, I'm a happy person, then I'd get told off for it. And if you talk to your patients, you often find exactly that pattern for them. We put together 4 little descriptors of different personality types, so different emotional types, if you like, types of family. And we show that to our patients, and most of them will go, yeah, that one, that one, that one. They can pick this stuff out. And they're often surprised that we know about it. So the big 4 family types, the family you want to grow up in is the validating one. Now, we don't see as many of these cases. We do see them, but they don't tend to come to this emotional phase 3. They'll be the person who, if you like, decided they got a big diet and felt good about it, and then started binging, but without the big emotional triggers, etc. The person who comes from a validating family has grown up with their emotions supported. They've been taught by experience, if I express how I'm feeling to my family, that's treated as being serious, it's treated as communication, it's responded to appropriately. Unfortunately, we also have a bunch of people who come from this other group. These are people that Marshall Lenehan talked about in terms of borderline personality. But the same pattern exists whether you've got that diagnosis or not. So I'll take you through the 3 different types. In the typical family, and the word typical should be understood as being inverted commas here, the rule there is don't do emotion. We as a family don't do emotion. We focus on success. We focus on achievement, but we do not focus on emotion. And if you show that you're happy or sad to the neighbors or whatever it might be, you are told off in uncertain terms. That's a pattern. Sorry about the coughing. That's a pattern that you'll see in a lot of families where, in particular, I find these are families that have grown up, if you like, having made something themselves. they've got some money at last, and they're looking after their position in society. I don't want to look like I'm failing here. For those of you who are my generation, this is the role that Alison Steadman would play in any kind of drama. We don't do emotions; we're all absolutely fine. Next time is the perfect family. Now, here you're allowed emotions as long as they're good ones. If you say the world is a wonderful place, brilliant, wonderful, but don't show any negative emotion. Don't show anger, upset, fear, because they're not tolerated by the people around you. You've got to imagine a slightly snooty voice and someone going, we don't talk about that sort of thing. That's where you start hearing this kind of family come true. And then you've got the more obvious emotional chaos family, which is the chaotic group, where you've got a degree of emotional unavailability, which is about, for example, parents who are drunk or drugged or have their own problems, etc. There's often a lot of distress amongst family members. And if you ask for any support, you do not get it. You get anger. I'm thinking of a former patient of mine, named Pearl. She was 18, lovely young woman, had an eating disorder for a few years. And part of that was she just could not bear the fact that her mum couldn't do emotion at all. Pearl was very kind of, if you like, she was an 18-year-old who managed to survive a hell of a lot in family terms, which I think I was very, very impressed by when I met her and when I heard all about what she'd been through. But she's somebody where, if she took that to her mum had mental health issues of her own. I suspect from what I heard, she was more borderline, but it could be in bipolar, depending on which diagnosis you heard. What Pearl had learned was anything to do with mum emotions gets priority. Anything to do with me and emotion gets ignored, or I'll get hit, or anything like that. So if you think about the patients you see who have trouble dealing with their emotions, they probably fall into one of those three patterns there. And as I say, this is often to do with the way the family's raised you. But can be perpetuated by the stuff that happens in your everyday life since then, and the ways in which you ignore the good guys and tend to hang out with the dodgy people. All of that lot can get re-triggered. In adulthood, any of that can get re-triggered. So if you're doing your best to get along, having a normal kind of life, and then somebody acts with you as if you've suddenly broken some code, you're likely to self-blame. That's what we see all the time here. So what does that do? This is where we shift over to the Jeff Young stuff. I know that he and Martin will not kind of engage in any kind of linking together, but sorry, the rest of us are going to have to do it for them. What you end up with is belief emotions are not safe. Don't do it. Don't have them. Don't express them. The emotion inhibition core belief that Jeff Young talks about. It's not safe to have an emotion. It's not safe to express an emotion. So you try not to ever express them or have them. You avoid situations that could trigger them. Or if they come along, then you find ways of expressing them, like binging, for example. In short, you've got the avoidance and the safety behaviors, stopping you triggering emotions or getting rid of emotions once they're there. I'm hoping this makes sense in terms of the kind of people that you see. And it's worth remembering, if you work with young people, they may still be in this environment. They may still be in that situation, but then some adults are as well. They grow up with parents, or they have a partner who makes them feel this way. A huge amount of our job is help the person learn to express emotion, despite the fact that they've got the perpetuating factors either in the world around them or inside their own head. We want people to get to learn to express emotions in an appropriate kind of way, to understand them appropriately, not to keep beating themselves up as a result of having them. So what we try to do, first of all, is normalize the experience of having emotions. We want people to think, okay, I feel upset. That is not a bad thing. That's just a motivator. That's a kind of, that's how I am. I'm going to accept that one. So instead of I've got to find a reaction to it, and if you're thinking there are other therapies that come closer to this way of doing it, of course there are. Good for them. But we don't want people to learn emotions are bad things. So we need to help people learn emotions are normal. Emotions are inevitable and actually quite valuable in lots of ways. DBT, which I do love, I love any effective therapy dearly. DBT I'm particularly fond of. Teaches you how to tolerate those emotions. If you've done DBT work, then you'll know what that looks like. It's about how to let the emotion wash over you, how to urge serve, how to avoid using behaviors when you have emotions, etc. So you start learning, I don't have to actually be driven by those emotions into inappropriate behavior. But really, what we're after is teaching people that emotions are things you can address and that you can do so in everyday life. So, I want to be able to say to people, you've made me happy, you've made me sad, you've made me angry, whatever it might be. And I want my patients to be able to do that sort of thing as well. And, I often say to them, look, there'll be times when you're thinking you hate my guts. That's okay. That's absolutely all right. I actually say this in the first session now. There'll be times when you hate my guts. That's okay. I don't need you to like me. I need you to get well. And that often comes up partway through with the patient going, yeah, well, you said that I was going to hate your guts sometimes. Yeah. Is this one of those times? Yeah. Um, and of course, we work with those emotions from different angles according to need. We start simple, we get more complicated. That should be our motto throughout. If you're familiar with the term Occam's razor, that's what we're talking about here. Do the simple stuff first, see what it does. If it works, brilliant. If it doesn't, quickly move on to the next bit. So the short approach is maximal benefit. Hopefully, it'll make some sense as I go along. The way we explain this to patients, we use this thing on the right called the Newton's cradle. If you're familiar with Newton's cradle, it's that set of balls on the left there. The left-hand ball swoops down, the right-hand ball pops up. That's what we see. That, of course, is an illusion because the balls in the middle make a difference. So in the diagram on the right, you've got the trigger event on the left, you've got the outcome or the behavior on the right. And it looks like those are the only things that we focus on. But actually, we need to focus much more on the emotions and core beliefs in the middle. Because those emotions and core beliefs are vital for going from that situation to that behavior. And that's something I want you to just hold on to. That when we see behaviors happen, they're not happening at random. They're not happening out of the blue. They're happening because of something that's operating at a level we can't see yet, but which we can find out about. So just imagine the ball on the left is a trigger. That's going to activate your core belief about yourself. That will in turn activate an emotion. And we might use binging or another behavior to block out that emotion. That's the model that we'll talk about with patients. So they can see, oh, actually, what that could make sense for me. We have to help them identify. They're normally fairly good at the trigger. They're normally fairly good at the behavior. But the cognitions, the beliefs, and the emotions in between, they can be terrible at. Our job is to help them get better. And it's also worth explaining to your patient this is a two-way process. It's not just a trigger happens, I end up binging, but actually the binging makes me more vulnerable next time round. So the binging or whatever behavior it is, but to add to your negative emotion, that in turn adds to your negative core belief. That in turn makes you more sensitive to the trigger event. So we've always got to remember this stuff isn't a one-way street, but we see it very much, if you like, trigger to behavior. So what I want to do, there's a whole set of different techniques. I've written them down the side there, where I said Occam's razor, keep it simple. We'll give people a copy of a diary. Again, this one's available online, which details all the issues at the bottom right there. What's the last time that I binged, took laxatives, vomited, whatever it might be? And then key questions: what kind of trigger was around? What kind of behaviors did I use? What thoughts did I have? Those core beliefs. What emotions? And then a kind of column for think your way out of it this time around. Instead of jumping in and saying, right, now I'm going to be, now I'm going to overeat, now I'm going to start myself, whatever it might be. Think about what the potential consequences are of using each of those behaviors. What we're trying to do, of course, is teach the person that the safety behavior is very short-lived and not worth the candle. That's broadly what we're looking at here. But the stuff I'm going to go through is primarily the stuff on the left, starting off with a change in triggers and situations, working our way down to the work from the core beliefs. Any questions about that model? Yeah, look now.
Hi, sorry, I can't see it really clearly, but did you also say other behaviors like self-harm? Could you should just map that straight
Yeah.
onto there as well?
Yep. Behaviors like self-harm, behaviors like drinking, etc.
Yeah.
Risky sexual behavior can all map into this sort of stuff. So if you're thinking, yeah, but my patient doesn't have a binging problem or an eating problem, this is still a model we find very helpful. Does that make sense, Lubna?
Yeah, it does. I'm just thinking of a patient who goes from restrictive into binging, and then because she's binged, she'll self-harm. So it feels like that will, yeah.
So there you'd be looking at, on the left, the trigger would be, I have binged. Core belief, I don't know. Got to find out what that says about her. I feel out of control because I've binged. The emotion might be anger at herself. It might be regret, whatever it would be. The way of killing off that emotion is, okay, cut myself.
Yeah.
Or get drunk, or whatever it might be.
Yeah.
So you're always compartmentalizing a little behavioral chain here. It's akin to chain analysis, if you're familiar with that from psychology field. Right. So we start off by targeting the trigger. This is something we can do occasionally. It's more in the case of, if you like, habit type behaviors. And it goes back to habit reversal. The technique. They teach it in IAP, but it doesn't get talked about much elsewhere, certainly not in eating disorders. But habit reversal is a good thing to consider when the person says, it's just a habit. I don't think about it, I don't do it. It just happens. And what you see, habit reversal is around things like repetitive behaviors, such as skin picking, for example, pulling your hair, Tourette syndrome. And what you're doing there is trying to change the behavior by engaging in an incompatible one. So if, for example, I stammer, or if, for example, I pull up my hair, the job with Asrin and Nunn's technique is they identify the cues for when that's going to happen, and then engage in a behavior that doesn't work alongside that. So if I've got the urge to, for example, make myself sick, then if I need to use my fingers to make myself sick, an incompatible behavior might be stick my hands deep in my pockets, keep them there, go for a walk, anything that stops me actually vomiting at that time. And that's something we use. We use it a bit at the beginning of therapy for some people. And if it works, brilliant. If it doesn't work, you want to work out fairly quickly so you can say, right, let's move on to the next approach. With habit reversal, it's always identify the behavior, identify an incompatible behavior. Like I vomit sometimes, it's just a habit that I have. I couldn't do it with other people around. Okay, so how do we make you aware of what's going to happen? What happens in particular situations or particular times of day? And when you've got that coming up, say you're on your way home, etc., you've got that urge to vomit. What could you do that is incompatible with that? So when you get the urge to vomit, I want you to visit a friend, make a phone call, whatever it might be. And also monitor what happens to the urge, because the urge goes down fairly quickly. So the longer you can keep the person away from responding to that initial trigger, the better, even if you don't understand what the core beliefs or the emotions are. We essentially keep a record of the urge to do it, and the frequency that we get the urge to do it, and the person will learn. as I pay more attention to the cues, I can back off from using the behaviour. That's a start to, but it's not something you'll use a lot, so I'm not going to focus on it to any great degree. Next up, we want to work with the emotions themselves. Remember, we start out saying we're not even going to look at the emotions, we'll use habit reversal. Now we're saying, okay, we need to understand what emotions the person is experiencing. And likewise, we'll go on to core beliefs on that one shortly. So we have the simple flashcard, rather like the thing you see here. It's on the website. We just say to people, okay, over the coming week, I want you to note down which of these emotions you feel, put a tick every time you feel them, and we'll see which of them most commonly come up in your life. And if the person says, I can't think about my emotions, what would somebody else have felt like in that situation? That's normally a pretty good way of doing it. And so what we'll see often when we get something like this is maybe anxious has loads of ticks or angry has loads of ticks. Often not jointly. So, okay, what can we do with that lot? Well, this is where we can use exposure if it's an anxiety-based problem. If the person's talking about anxiety, if they're talking about disgust, etc., this tends to work. If they're not, then I'll come on to that after this particular one. Okay, so exposure with response prevention. Thanks to the exposure we're using about food earlier on. This is aimed to delay the person's binging or their compensatory behavior like vomiting until the anxiety goes down. Remember, anxiety fades naturally, but it takes 30 or 40 minutes. So our job is to keep the person from running away from it. That's the response prevention bit. So when I've got a patient with urges to binge eat or to vomit, then my job is to help them sit with that urge long enough they realize the urge goes down without having to use that behavior. This is absolutely standard stuff in the field of psychology. That we wait for the emotion to go down, and it happens with, again, a bit of psychoeducation would be useful. It happens because we run out of adrenaline. We have just so much fight or flight response before we just peter out and can't do anymore. And what I'm looking at here is 30 or 40 minutes, keep monitoring the anxiety as the person goes along. I try to avoid anything that's going to distract from the anxiety, but focus in on it. So I'll use a distraction that's like putting together a really big diary about my behaviors, alternative incompatible behaviors, what's going in my head, what's the third cognition I've got. Just in the form of a really big diary with lots of columns, because by the time the patient's finished, they're often going, you know what, I can't be bothered anymore. Really can't be bothered to be sick. That's great, because what the person is learning is the urge to throw up or the urge to binge or whatever it was goes away if you sit with it long enough. They're so used to the idea of immediately react, bang, I binge, I calm down, that they don't ever realize that they would have got to achieve calm without pathological behavior. And that will work pretty well if it's kind of, I feel like binging because I'm feeling anxious. That's great. Unfortunately, it doesn't work for all emotion. And the reason for that is some emotions don't work in the same way. So with anxiety, you run out of adrenaline, you run out of energy. You just feel calmer because biologically you can't feel any more anxious. However, that's not how things like anger, shame, or loneliness. They're much more cognitive. As an example, if I feel angry, I try not to do too much, but it will happen. If I feel angry, it won't go away just because I sit with it. Actually, what happens is we tend to rehearse it. Anger is one of those emotions which we routinely talk our way through. So, as an example, if I, at the end of today, get in my car, drive along the motorway to get home, and a car cuts me out terribly. I'm just driving along, and suddenly, whoop, car zooms across to get off the motorway, and it nearly hits me. that first thing I'll experience is real anxiety. Oh God, I could have died. That's really scary, and the anxiety will be high and spiking. But after about 30 minutes, that anxiety will have faded because I'll run out of adrenaline. However, the anger that I feel at this other terrible driver won't have faded because I'll keep talking about it. I'll keep verbally rehearsing it, either in my head or outside of it. So, I'll get home an hour later, and the first thing I do when I walk through the door is, I'm bloody well going to complain to the lady, how dare they cut me up, etc. In other words, some emotions, like shame, like loneliness, like anger, we run through in our head time and again. Why am I so lonely? Why does nobody like me, etc.? And they don't fade because they're not fueled by adrenaline in the same way. So some emotions won't respond to exposure. That's the point I want to come back to. So if you're sitting there and you're thinking, my patient is up their eyeballs in shame about the trauma they experienced, I wouldn't try exposure work. You think, okay, this particular patient needs something that's more about dealing with the emotion that they're experiencing, not just working your way through a protocol. Any questions about that before I talk more about what we do at the end, etc.? Yeah, Olivia.
So I was just looking at the middle bit, so sitting with the emotion, so would mindfulness be, I see there it says mindfulness would be an approach to kind of reduce the anxiety. I guess when I think about mindfulness, it's like sitting with the emotion, but is that because it's like cognitive diffusion that actually it's not helpful in this case?
I have no problem with mindfulness, no problem with relaxation, with self-compassion. They've all got their place in the appropriate part of the pantheon. But here, what they do is they clash with exposure therapy.
Okay.
Because what they do is they make you feel that bit calmer.
Mm.
If you want an example, systematic desensitization, it used to be used as a form of exposure therapy. It's now not recommended at all. Because what it does is it stretches out how long it takes you to get calmer, or to get better, rather. So if I treat somebody with, say, panic disorder using graded exposure, I can do it in half a dozen sessions. If I use systematic desensitization, it's probably 30 sessions because every time I've dimmed down the anxiety level. So I've no problem at all with mindfulness, etc. But I wouldn't put it in as a way of reducing the anxiety here. I want that person to experience the anxiety.
Got it.
I mean, I'm going to sound really horrible here, Olivia, because I am. But what I'd be doing at this stage would be talking to the person about their anxiety. How's it feeling? Where are you feeling it? What thoughts are going through your head, etc. I want that person focusing on that anxiety so that after a while they're learning, do you know what? It's gone down. Rather than blocking it out from the beginning.
Okay.
Does that make sense?
Yeah, definitely. And the alternative is like then the alternative action. Is that what you're meaning? Distraction, e.g. mega diaries, alternative, incompatible behavior.
Yeah, so a bit like what we talked about with the habit reversal. Get them doing a behavior that doesn't take their mind off doesn't take their mind off the anxiety, but it does take them away from using the behavior.
Okay. So it's distraction from the behavior, not the emotion itself.
Not from the emotion, no.
Yeah. Okay. Thank you for clarifying.
Okay. Look that. Yeah.
Yeah, I guess I was just adding on to that 'cause something you said, which was, I think, for me, was really helpful, was about the adrenaline. We know it's that kind of that fight or flight, and it's going to stop. But if you can get them to ride it for that 30 to 40 minutes, they can actually see they will come down naturally. It's not like the end of the world. Being able to see, if I feel these intense emotions, nothing awful is going to happen to me. I can get through it.
And then to add to that, and if I do the same thing again tomorrow, I'll still feel anxious, but it won't get as bad, and it will fade more quickly. And then the day after that, it won't get as bad again, and it will fade more quickly. So it's about getting people to realize that learning will only happen if they actually sit with that, and they don't. What the patient often does is they learn that running away is the only safe thing. the analogy that I often use for patients is about panic disorder. So, for example, if I was sitting here right now and my heart was beating, I'm thinking they're all looking at me, they're all thinking I'm an idiot, etc. And my heart's pounding, and I'm worried I'm going to have a heart attack, etc. Then my safety behaviour is to just get up and walk out the door, and I'll feel much calmer. But I won't be able to come back and talk to you again, because I'll be thinking the only safety thing I've got is get the hell out of there, which means I never learn that I can talk to you. Again, same thing with the urge to binge, for example. The only way I learn that I don't end up binging is by learning that, when loved ones told me that my adrenaline level is going to come down, I didn't necessarily believe it. But after about 30 minutes, I could feel the anxiety coming down. But that's why we always get to rate anxiety on that 0 to 100 scale. One of the things about exposure, you feel terrible, like a terrible human being as a clinician, because you're getting the person to rate their anxiety. It's 100, 100, 100. And after about 20 minutes, it goes down to 90 and then 80. And you think, oh, thank God for that. I'm not a terrible person at all. Because the person has to learn, the anxiety comes down. And we as clinicians have to learn that as well. If the minute I see a patient is anxious, I try to calm them down. I try to do compassion work or relaxation. What I'm doing is I'm keeping that patient reactive to that trigger. They'll always feel anxious because I'm supporting the eating disorder, not supporting the anxiety of the eating disorder, not supporting the person. Remember what I said about needing to be tough sometimes? Welcome to my world. Anyway, back to those other emotions. This is where we're on core beliefs. Okay? The reason that I am likely to get angry in a consistent way is I've had a traumatic background, and it's something to feel resentful. It's not always going to be about someone cutting me up on the motorway, but the person who cuts me up on the motorway might activate that for me. So my core belief might be, people are horrible, people are nasty, you can't trust other people, stay away from other people. Then someone tries to cut me up, and that activates all of those beliefs, etc. So now we're not talking about the anxiety and that kind of that link into the physical reaction of the adrenaline pumping, etc. Now I'm running over and I'm rehearsing all of the things that are dangerous and bad about the world. When you're on that pattern of belief, or that pattern of emotion, then exposure isn't going to work, because it's not the adrenaline, it's not going to come down, it's not that high. So what we're looking at is the core beliefs. This is where we start looking at some of the more, if you like, long-term trauma type cases that we see. I've worked with trauma cases in my lifetime. I think it's a pretty common bloody experience. You might have noticed. And those, there are various traumas that get you here, and some people deal really well with trauma. Other people don't. It often depends on the kind of background that you had. So not everybody who's had a traumatic experience will have these problems, but for a lot of people, where there's predisposing factors, they will do. Now here we're into the same territory as other disorders again. So, for example, there's going to be things I talk about, particularly around imagery rescripting, which are very similar to things like PTSD from people who've had bomb gulf next to them, or people who've had rape experiences, and that forms part of the group that we're working with. But it doesn't mean that we have to treat these people differently. So here, what we're doing is we've got somebody who's got a very strong set of negative core beliefs about themselves, and we have a series of ways of helping them to work with those. The kind of core beliefs I'm talking about fall into two broad kinds. There's the kind of more central beliefs. I am vulnerable. I am broken somehow. I can't trust other people. Abandonment. Abandonment is such a big one with eating disorders. People will always give up on me. I can't trust people to stick around. And then you've got, if you have more compensatory beliefs, how do I cope with that fear that people are going to give up on me? And one of those things might be perfectionism. if I work really hard to get everything absolutely right, maybe people won't think I'm as bad as I think I am. Maybe I can fool myself that I'm okay if I just keep on trying, keep on trying. You get subjugation and self-sacrifice, using the youngest terms, where you do things for other people to make yourself useful. If I believe people are going to dump me, then maybe if I make myself useful, I'll be okay. And that's the kind of core from many pathological relationships, where the person believes, well, yes, he's hitting me, but I shouldn't do anything about it because if I do, he might leave me. That's not a great way of coping, but if you don't believe there's any other way, then you can start to understand it. And of course, you end up getting hit and you end up believing these things even more. And then a really important one, emotion inhibition. Remember that one? That notion of it is not safe to show my emotions. It's not safe to have my emotions. I can't talk about them, etc., etc. Often we find our patients are very high on levels of alexithymia. I think sometimes stuff that gets into the ASD category these days has a similar kind of background to it as well. The person doesn't get emotion because it doesn't feel safe to have it. Like I think of patients where they just didn't believe that emotions were safe things to have, and so they backed off from having them, much as humanly possible, which of course ain't healthy. Those are the kind of core beliefs that we're looking at. And these are the techniques that we use in roughly the order that we'd use them. Now, I'm actually going to take you through a couple of cases, if you'll bear with me. I'm feeling expansive today. I'm going to take you through one who binged but was actually underweight. And I'll take you to another who was binging at a normal kind of weight, etc., though could have been overweight quite easily. And I'll give you an idea about the way we think about this stuff. So we work our way through these methods as much as we can. So we start with psychoeducation about invalidating the environment. Person number one, Jenny. Jenny was a lovely woman. She was probably aged about 40. And her big problem was exercise. She was just a bit underweight, but her big problem was that she would walk and walk and walk all day. We got to her pedometer at one point. She was walking about 40 to 45 miles a day, which is a lot of walking if you're not used to it. Buggy at 10,000 steps. This is serious walking, but she'd get up at 6 in the morning, haul on her trainers, be out the door, and would keep walking all day. When she got back about midnight, she'd get back via the shop, having bought a whole pile of food, would then eat the food in her flat to get back her energy. I remember describing once talking about buying a loaf of bread and a block of butter and basically eating the bread and the butter as part of how she kept her energy up. And then she'd be asleep and then back out the door the next day. Never spoken to her relatives, nothing like that. So first thing we did was talk about the environment she grew up in. Now, Jenny grew up on a farm in Ireland. Sounds a bit idyllic, etc. She was about 10 years younger than her youngest brother or sister. She had several brothers and sisters, but she was the gift, if you like, in the family, as they called it. And she had a really nice childhood up to the age of 6. And then Dad got ill. Dad got ill, developed cancer, and the whole family went into emergency mode. Half the family was now looking after Dad, half the family was looking after the farm. The one person no one had any time for was a 6-year-old who was wandering around with no great understanding of what was happening. So what Jenny learned was get out of the house. Go out of the house, and then whatever the heck is going on with Dad, you don't have to be around for it. And so she learned to go for a walk. I think at first she went out and played with the ponies or something, but then she learned to go for a walk, and she just kept walking. And she'd walk a long way, and then come back. And when she got back, everyone was exhausted. No one really seemed to care that she'd been out, etc., for hours. And that was what her life got to be like for about 2 years. And then Dad died, and it went into meltdown about how to sort things out around Dad dying. All this time, what is she learning? People aren't there for you. Don't show your emotion. Don't show what you're feeling. Cut yourself off from other people. Isolate yourself. Those are the things she's learning because they fitted at the time. This is a key thing to remember about core beliefs. They make sense at the time that you do them. Later on, they look bloody weird, but at the time they made sense. So what she learned was keep quiet, don't show your emotion. If you show your emotion when you get back in the evening, everyone just says, "Oh, shut up, we've had a terrible day." So by the age of 8, she's got these really firm core beliefs laid down. And of course, now the world changes. Now people have got more time for her, but she already has laid down this pattern of beliefs of, but people don't care about you. So she doesn't let them get close enough. And again, you can think about any kind of emotional background, any kind of abusive background might have had the same effect. But here, what you've got is something where you couldn't say, "Ah, he did that to you." What you've got is, it was the circumstances. I couldn't do it here. I can't blame him. And that's a really big problem. You can't blame him. So in terms of what's called attribution theory, she attributes it all to, it must be me that's the problem, and it must be something that goes on forever, and it must apply to all of my life. So what she learned was cut the emotions. And that led to her having this exercise habit. It led to her overeating to cope with it. And 30 years later, she's still walking around London. So what we're doing here is a historical review and contextualization. That second stage, we want her to think, "Oh, it makes sense. What you've done makes sense there." So we're trying not to leave the person thinking it was about you being a stupid little girl or whatever, which was a phrase she'd heard enough. Thank you very much. We want her thinking, okay, from that historical review, it does make sense. Third stage, what's the evidence that this is still the case? Not evidence that you are this stupid little girl, but what's the evidence against? And what we found was, many years later, we couldn't find any current evidence. So we learned to figure out, so what's the evidence people give up? All of that came from 30 years. Okay, what's the evidence that you should keep your mouth shut? All the evidence came from 30 years ago. Are people trying to get in contact with you now? Are they trying to be emotional with you now? Yeah. So what she has to learn here is that the emotions that she's developed, the ways to think she's developed, were about back then. So remember what I said earlier about attribution theory? With attributions, what you want is the person to learn that it doesn't have to be global, it doesn't have to be internal, it doesn't have to be stable. In other words, that applied back then. That applied to a particular situation where your dad died. And it wasn't about you, it was about the whole situation. It was external to you. Whereas her attribution is, it's internal, it's about me, it will always be there. And it's something that applies to all of my life. So that's where we're in stage 4. We're challenging the attributions. What's the evidence that you can, if you like, blame yourself, or that other people might be interested in you, etc. So we started looking for evidence that other people might be interested. And she told me about her family and the WhatsApp group they have with the family, which she was on but had never replied to, etc. And the suggestion that I came up with that we agreed she'd try was, why don't you get onto the WhatsApp group and basically try talking to the family about the situation. Try talking to your family about where you are. Just tell them that you're alive, because they were desperate to hear from her. And her first reaction to that was, but they'll just tell me off. They'll tell me I've been stupid for not being around. You might be right. I don't know. But can it get any worse than it is right now? So she tried that. She tried talking to the family. And lo and behold, family really wanted to know about her. They were really interested in how she was doing. So the really lovely thing that she picked up was, actually, if I don't blame myself for everything, then maybe it's possible to change those attributional patterns that lead me to have those core beliefs. That's the really key thing in a case like Jenny's. Can we shift that self-blame to the point where the person goes, maybe it wasn't me. that's as far as we need to go with Jenny. She actually got really good at talking to her family, realizing that they did care about her. She cut down her walking. She began to eat more normally, etc., because she felt like she might be worthwhile, which of course she hadn't felt for a long time. So that's great. That's a more cognitive way of going about it. Work with the attributions. It won't work for everybody. So now I'm going to give you a different case that takes you through to the other element, element 5, particularly element 6. So case number 2. Okay, case number 2 is Sharon. Sharon, when I first met her, was 28, turned 29 while I was still seeing her. I was treating her for bulimia nervosa. She had a BMI of about 24 and a half. She had a child, 1 5-year-old, and she had bulimia for a long while. And she had a relationship with the father of her child, which was rocky to say the least, because she was constantly certain he was going to dump her. She was absolutely certain he was going to go. Have you ever left? No. I'm still certain he's going to go. Okay, let's think about where that comes from. So we go back to psychoeducation. Talk to her about invalidating environment. She could make sense of it, but couldn't connect it to her because she was going along the lines of, but no one's ever done anything terrible to you. This is a common pattern you'll see if you attribute stuff to other people. You're not very good at saying maybe other people did dodgy things to me. So that's where we went for the historic review. What had happened to her? I would say this is not a pleasant story. But if you're in this field, I doubt that you're in it for the pleasant story. So please bear with me. And again, you can imagine, I've heard the same kind of outcome from more overt sexual abuse or physical abuse. But this is more of a neglect case, which had very profound effects on Sharon. So when Sharon was 5, she and her younger brother, he was age 3, they lived with their mum. Dad wasn't around. I did think at one point that might come up, but no, Dad never actually turned out to have been there in her childhood. She could remember. I think he probably got when she was aged about 1. So she describes being a happy young child up to the age of about 5. The problem in the family of there was that Mum was clearly looking for a boyfriend. Her mum found a guy, and it all looked brilliant, except that the guy lived 200 miles away, which meant that they could only meet very occasionally. When he happened to be in their bit of London, that was the only time they could meet. And my guess is that Mum was a bit frustrated by that. I got the impression that Mum was the most kind of human sensitive people as time went by, but that may just be my bias about the case. Anyway, so Sharon's age 5, brother's age 3, and Mum's frustrated about this guy not being nearby. Sharon remembers very clearly waking up one Saturday, going to watch TV, and her mum is up and dressed. And she says to Sharon, I'm just popping out. I'll be back shortly. Look after your brother. Don't let him get upset. Sharon thinks Mum's going out to buy cigarettes or something, or going out to buy breakfast or whatever it might be. Mum pops out. She doesn't come back for about 13 hours. That was terrifying for Sharon. And it meant that she had to spend a lot of time looking after her brother if she did this and trying to make sure he was okay. So she spent a lot of her time on that day just trying to keep her brother happy and saying, oh yeah, Mum will be back shortly. Mum must be sleeping, whatever she could say. In short, she couldn't do kind of anything other than try to keep her own emotions under control for her brother's sake. At the same time, she was worried. I think the term shitless is a good one here, about the possibility that Mum was gone or had died or was never coming back. Mum comes back in the evening, and it turns out Mum has gone off to this far distant boyfriend. At the time, she was living in London. He was in Manchester. So she'd gone off. to see him had come scurrying back, deeply apologetic to the children, never happen again, etc., etc., except they did. And Mum would prep some food, and she'd go away early on the Saturday. She'd come back later and later on the Saturday, and the kids were not happy about this one, clearly. But Sharon's still doing the "I've got to look after my brother" side of things. Goes on for longer and longer. Then one night, Mum doesn't come back. And now, of course, Sharon and her brother very, very panicked about what's going on. Turns out Mum's decided to stay overnight. Now, with a 5-year-old and a 3-year-old, I can't help thinking that doesn't sound normal. It certainly doesn't sound appropriate. But this is when you're a 5-year-old. You don't know that. So what's happening to Sharon is she's starting to think this is about me. She's starting to attribute internally it's about me. And it's gone on so long that it's always going to happen. And if this person is giving up on me, then, and it's probably never going to come back, then that's going to happen to everyone. So her pattern of attribution is becoming more and more internal. It's me. Her belief system is becoming more and more people abandon me. She's thinking it's going to go on forever. And she's thinking I still can't show my emotions because I'm looking after my brother. So this goes on for about a year. And then Mum by now is going off on a Friday night, coming back on a Sunday morning, or later on Sunday, and is telling the kids, don't tell anyone this is happening. Basically, the kids live alone at the weekend. 6 and 4 at this time. Not what I would call a comfortable or stable existence, but Mum is clearly much more dedicated to the relationship than she is to family time at home at the weekends. Here, you can start to see how anybody looking at it from the outside is like to think, what the hell was Mum doing? But remember, when you're 5, you don't think that way. A critical thing here is that when you're young in particular, or when there's been a big event that you had no control over, like a rape experience or a bomb going off next to you, you don't code it away as something logical. You code it very emotionally and perceptually. This is why imagery scripting gets used for all of these, because it's about how you deal with very emotionally coded material. Anyway, one day it all goes horribly wrong. The aunt comes round, looks through the door, sees the children's feet where they're lying watching the TV, because they've been told don't answer the door. But the aunt reckons something terrible must have happened to Mum, calls the police. The police come around, knock down the door, and take the kids away. They contact Mum, who comes scurrying down from Manchester at her own good time, and apologizes. Sorry, officer, never happened again. One-off experience, etc. Desperately sick relative, whatever it was she said. And the police agree that she can take the kids home. Although for some bizarre reason in those days, maybe social services just didn't get involved in cases like that because nobody ever seemed to follow it up. Anyway, Mum takes the kids out the door of the police station, takes her around the side. Sharon's really worried that they've let themselves get spotted and that they've done the thing that Mum told them not to do. Mum bends down in front of the 2 kids, and Sharon thinks that maybe Mum's going to say something nice, and Mum just slaps Sharon on the face and says, "Don't you ever do that again." So what Sharon learns is, don't talk about this to anyone, because it's not safe. Nobody supports you. The police don't look after you, etc., etc. So what she's learning is, if you like, not just it's about me, but it's a permanent thing. It's going to happen all the way through my life. So it's going to happen all the way through. Don't trust other people to look after you. So abandonment just gets more and more buried. Then we look at the evidence behind all this, and all of the evidence again sounds like it's with her childhood, except that she's been through multiple relationships as an adult, and they always end early. She always kicks guys out. And when we talked about why she kicked people out, from the relationship, it was always because they're going to give up on me, so I'm going to give up on them first. I'm not going to give them the opportunity to dump me. I'm going to dump them first. So she'd been through multiple relationships, and she had real trouble with her current boyfriend because he'd been around for about 6 years, and she could not make sense out of it. The one thing that would happen would be he'd go off to work, and on a Friday, he'd go out with friends from work for a drink. And on Friday, she would be really, really angry the whole day long, and she'd be shouting at him in the evening. She'd say, "Go on, go off and insert your own terms here for have calm knowledge of another woman." Because that was what she was having convinced about. He was going to dump her. She just didn't have any control over when. So she was trying basically to kick him out before he could kick her out. That's the big picture here. Does that make sense enough to people? Okay. Oddly enough, it made no sense to her whatsoever. Because from her point of view, she's the person who people always dump. You can listen to the story and you can think, well, logically speaking, it's got to be about what was done to her. From her point of view, it's got to be, this is who I am. I drive people away, etc. And the only sense of control she's got is I can drive them away when I say so. So we looked at her attributions, and as you might expect, it happened when she was young. It happened for a long time when she was young. She had no logical capacity at the age of 5 to challenge this and say, maybe mum is not being appropriate. So what she developed was much more attribution, much more core beliefs that say, it's me, people give up on me, don't show your emotions, etc. Don't talk to people about this kind of thing. And basically try to get your dumping in first before they dump you. That's the kind of belief she got. The attributions were very much, it's me, it will always happen. But that's the state she was in cognitively. In behavioral terms, she was very heavily to binge eating, bulimic. She would binge 4 or 5 times a week. Was kind of holding her weight around 24, 25 mark. But she'd binge, she'd vomit, etc. But the first thing we did was work on her eating. I've already told you about why. So we piled into her eating. Let's get your eating straight first. Okay, we did that. We got her eating down after about 6 sessions from 4 times a week down to about once a week. But the once a week was, guess what? Friday evening after the boyfriend had left for his drink with his colleagues. So she'd be really angry all day. She'd turn to get off and, basically whatever he was going to do with whomever who was going to do it. And I believe the word floozy was used at one point. I've never heard it used in any other context in my life, but the word floozy came into that. And she'd get really, really angry. And because she couldn't tolerate the anger, she would binge. That was her way of shutting off the emotion. And of course, the danger when you're in that situation is you might get successful. You might actually drive him away. You might actually send this guy off to the point where you lose the person who's actually the most sort of straightforward person in your life, as far as I can see. It sounds like he was a stubborn bugger, which probably for her was a good thing. But from her point of view, this is all stuff that was buried away, not verbally. Remember, as an adult, you can hear her tale and you could be thinking, well, the logic of it is this and this and this, and what you should think or do is that. From her point of view, this happened when she was so young, she couldn't logic away. We know that up to about the age of 5, 6, 7, we're much better at storing stuff away in kind of non-verbal, much more perceptual, emotional terms. If you're familiar with the social anxiety or the PTSD literature, what we end up doing is we put stuff away in encapsulated memories. If you've never heard of an encapsulated memory, it's like a really kind of unpleasant traumatic memory that we lock away and we try not to look at. And in order not to look at it, we will cut ourselves, we will binge, etc. But when you try to open that belief up logically, it's like a little hedgehog, which is why I'm wrapping my hands like this. I'm not just trying to get warm. When you try to get into it, it will resist being pulled open. It'll pull back. Because what the way we try to engage this stuff in cognitive terms is entirely inappropriate. If we talk to the person logically about stuff that's emotionally encoded, it doesn't tend to fly very well. You know that notion of felt sense that Helen Kennedy talks about? The notion of it just feels that way. That's what a lot of our patients have. They have that notion of there's a felt sense of it's my fault, rather than it being a logical decision that it's my fault. Now, part of our job is to make sure the patient learns, actually, you know what, that wasn't your fault. That wasn't something you created. So what we've got is beliefs that are locked away from, if you like, the kind of talk about attributions, etc., that I would have had with Jenny. This is where we start using techniques. Now, I've had people ask me, could you do this with EMDR? Could you do it with a variety of other different techniques? Twitch, CRT, whatever it might be. I don't know. We're just going for quick here. So we use imagery rescripting. Now, this is a technique that was first devised by people like Thomas Schmucker as an approach working with PTSD. And you'll find it's scattered all over the literature. Judith Beck used it. Who else? Marianne Layden, Corey Newman, Jeff Young. They all use imagery rescripting because it's a way of getting into those very, very childhood beliefs, those very emotional, perceptual beliefs, rather than trying to logic your way through them. So again, schema therapy uses this stuff. I've not seen it used in DBT, but I've seen it used in multiple different therapies. So this is not something that we invented by any means. Vartolia Hanny was the first person I ever heard talk about this in terms of eating disorders, and she was brilliant at this. She used it more for body image, which I'll talk about after the break. But right now, thinking about that very traumatic experience that someone like Sharon has had, where they can't logic their way out of it. So what we do with imagery rescripting is we say, right, what we're going to do is we're going to go through that event in your life as an image. Why? Because we want the person to be able to open it up. We want to be able to open up those beliefs. And getting into it as an image, talking about the emotions, talking about perceptions is a good way of doing that. And then we're going to bring in a different script, same thing, but this time bring in an adult logical self. Different people argue about who you should have as the adult involved. Myra Cooper says, get a strong adult. Jeff Young says it's got to be the therapist. The therapist is the only person who can save you. I'm not convinced about that one because I want the person to be thinking, I can make this change. Then I go more with the original, Corey Newman, Marianne Layden, Thomas and approaches, which is get the person themselves in there. And they might say, but he's twice my size in that image. Do you need a gun, a dog, whatever it might be? It's your image. You're going to play with it. So, taking you through it step by step. First thing I do would be I make sure I had a good 40 minutes to do this, and no one's going to be interrupting if it's online. We have been successful in using it online as well, I should stress. But if it's going to be online, then it's something where the person can ensure they've got quiet for the hour. We're going to spend about 40 minutes where we're going through this memory twice over. Some clinicians will ask you to close your eyes when you do this. I don't. And I don't say don't close your eyes, but I never ask the person to close your eyes. I think there's something about working with a largely vulnerable young female population and being an older white male in a profession that's full of dodgy older white men. I'd really rather not put my patient into a position where they feel uncomfortable. I'm trying to get through my whole career without being one of those dodgy white men, so please bear with me here. It could take a while to convince the world, but I'm doing my best with it. Anyway, back to what I do with someone in Sharon's place, if you like. I would say to Sharon, okay, what we do is just sit there, and patients will often close their eyes spontaneously and say, just sit there and tell me about what happened to you around a critical event and all that. Now, I thought she might pick the time that mum first didn't come home, or possibly something about Dad. I was still clinging on to Dad being a possible part of the story at this point. But she chose the time when the police came around. Okay, it's her story. That's what we'll go with. And you might need to do this a couple of times. We very rarely do it more than once, but I can't think of a time I've done it 3 times, certainly, because we're about shifting police attribution very quickly and very, very largely. So you've picked the time that your mum came after the police, picked you up. Where do you want to start the image? And for Sharon, start the image was in a waiting room with a policewoman and her brother. The brother's playing underneath the table. The policewoman is there in the room, and Sharon's holding the policewoman's hand because she's really worried about what trouble she's caused. That's her worry, not my worry. Okay, so let's talk about this, but tell me about it with as much detail as you can. How were you feeling in that room? What could you see? What could you hear? What could you smell? And getting her to talk through the story about how it went from I'm sitting in the room with the policewoman, my brother's playing under the table. It's a big table. The walls are all coloured in white tile. What's the policewoman wearing? What can you smell? Smell of bleach, etc. And I don't mind if some of this is kind of retrofitted memory. It doesn't worry me at all. I just want that person's emotional representation opening up. How are you feeling at the time? Really scared? What was it you were scared of? Scared of mum coming, etc., etc. We just tell the story all the way through to suddenly there's this noise. Mum has clearly come into the police station, is shouting at everybody. They all meet in the foyer of the police station. The police officer tells mum off. Blah, blah, blah. How are you feeling? What could you see? What could you hear? And then we got to the bit where mum is taking them outside the police station, and she remembers that mum was dragging them both by their arms. And she went around the side of the police station to where there were no windows. And that's when she hit them. And all the time, or hit her rather, all the way through. How's that make you feel talking about it? How were you feeling back then? You know, what could you see? What could you hear? What time of year was it? Was it cold? Was it? You know, it turns out it's autumn. It's a bit cold. The leaves are falling off the trees, etc. You want as much of that kind of detail as you can get. And this took us about 20 minutes. And when we got to the end of it, I asked the kind of key question, which is, okay, let's close that down. Let's come back into the room. Tell me, who was responsible for all that happening and your mum hitting you, etc.? And her immediate response, I was. It was me. Okay. Let's do that again. This time we'll do the re-scripted version. So we've heard the script of what had happened. This time, when we get to a critical point, then I want the adult you to come into the room or into the courtyard or wherever it might be, and be the adult in that situation. And so we're going through exactly the same scenario, starting off with the policewoman. Yeah, what was she wearing? Did anybody else come into the room? There was a policewoman with a cup of tea for her. Telling the story again, lots of questions about how she was feeling, lots of questions about what her brother was doing, what she could see, what she could smell. And then we got to the point where in the image, mum has taken them outside again, and mum is about to hit her. Mum's got her arm raised. Okay, now I want you to stop. And I want you to bring the adult you in. I want you to bring in the adult you, and I want you to do whatever that adult you says should happen right now to look after young Sharon and her brother. And this is where you get the real transformation, because you get somebody who literally, within their own attributional style, is very, I can't control anything, I can't do anything, it's all totally beyond me, I can't do it. Okay. What I want you to do is just do it as the adult would. And she was completely different. It was, well, the first thing I'm going to do is go and grab mum's hand. I'm going to pull her away. I'm going to push her up against the wall. I remember this one because it sounded quite brutal at the time. I'm going to grab her by the throat. I'm going to tell her that she can't be like that with the kids, etc. She's a terrible one. Basically, you've got this outpouring of bile about mum and how she'd been. What I'm hearing, of course, is understandable anger, something she's never experienced about this. She's always blamed herself. Now she's learning how to blame her mum for it. And it's a complete shock. And the nice bit is she did what many, many people do. In fact, the great majority do it without being prompted. But I always say at the end, is there anything else you'd like to do? You sent mum away. You told her she can't come back unless she's prepared to be a good mother and apologise to Sharon and her brother. Didn't quite give her a kick up the backside. She went. It was that kind of general tone. Okay, so anything else you'd like to do? I'm going to take Sharon. I'm going to take her brother. We're going to go to a cafe. We're going to get something to eat. I'm going to tell them it's not their fault. I'm going to tell them it's mum. It's this kind of terrible person who doesn't know how to be a good mother. And you got a very, very adult self brought into it. And then when we got to the end, you just asked 2 questions this time. Number 1, how do you feel right now? If the answer is exhausted, then you've hit the whole adrenaline pile all over again, which is brilliant, because if the person's feeling exhausted, it means they're really engaged with it emotionally. So that's always a good one. And then the other question, of course, is who was to blame for all that? Now, remember the previous answer was immediately, well, I was. This time round, the answer is, well, mum was. Of course she was. You can't do that to young kids, etc. So mum's getting the story, the butt of the blame immediately this time around, though she got none of it previously. In short, what imagery rescripting is good at is opening up that very encapsulated memory and allowing the person to bring logic into the situation. As I say, sometimes people say I'd get someone else to go in instead of the patient themselves. I try to keep it for the patient because I think they do engage better with it that way, but there's no evidence I'm aware of that says it has to be one or the other. There is good evidence about imagery rescripting. It can be really, really powerful. And it's very rare that I've ever found you need to do it more than once. I know Jeff Young, for their narcissistic and borderline patients, will often do multiple sessions. Not always sure they're needed. I remember talking to Arnold Arndt work saying, now actually you get most of the effect out the first time you do this. Just with borderline and narcissism, you often have to do multiple different situations for the person because of the kind of life they've had. And what we found, of course, was the binging stopped straight away. That was it for the binges. However, you don't stop at that point, because what we've done is we've done a lot of very good cognitive and emotional work. But if you want to ram that home, you do counter schematic work. Remember, most of us act on our schemas in a kind of consistent, keep it going kind of way. I'm essentially a lovable person, therefore people keep on loving me. That's okay. I don't have to operate too hard to make that happen. That's me saying my schema is accurate and therefore it can affect my behavior. With a lot of our patients, what they need to learn is how to do the opposite to what their schema has always told them. So Karen's schema has always been, don't allow people to get too close, don't talk to people about your emotions. Okay, what do we need to do to teach her that actually more generally you can let people get close, you can talk about emotion, etc. Now I suggested 2 things that she might try for homework, one of which she laughed at, literally laughed at, the other of which she actually did. And then she came up with one of her own. The one that I suggested that she laughed at was, how about talking to your mother about how this made you feel? And after she stopped laughing, wiped her tears, she said, Mum would never understand that in a million years. She just wouldn't get the idea that this could be anything to do with her. Okay, then we won't do that. But the thing she did do was talk to her boyfriend. I said, well, why don't you talk to your boyfriend about what we've been talking about here and see whether it makes sense to him, see whether you can explain it to him. And her reaction was, okay, I'll give it a try. She was pretty certain it would drive me away. He'd think that she was bonkers, etc., etc. And she came in the next week and said, yeah, the really weird thing. He said, well, that makes sense. That's kind of what I thought must have happened. Which from her point of view was very, very odd. She found that very bizarre because she was so used to the idea of he will reject me absolutely. But it was really powerful saying to her, you can share your emotions and it's not a bad thing. Things don't go horribly, horribly wrong when you share an emotion. That was quite a revelation for her. She got better at practicing out her emotions with other people. The other thing she did, which I wish I thought of, but no, she came out with it, was she went and saw her brother, talked to him about it. She knew he'd had mental health problems, but his were largely about anger. And they basically agreed immediately about mum being the problem. He'd never had the sense of, I can't talk about it because no one ever told him, don't show your emotions. But he spent his entire adult life never getting into stable relationships because of that belief system. So what this did for Sharon was get to the point where she was able to say, do you know what, mum will never get it, but I don't have to ruin the rest of my life by continuing to act like people are going to give up on me. My boyfriend actually seems to mean it. He's sticking around. I'm going to keep trying this. We worked on body image a bit after that, but that was pretty much all she needed to do across the rest of the therapy. It helped to get rid of that final 1 or 2 binges that have been very emotionally driven. So I'm recommending, if you want to do stuff quickly, imagery rescripting is a pretty good way of doing it. There's a couple of examples on the website, one about a case like this, one about a case around body image, which I'll talk about after the break. But any questions about that so far? Yeah, Olivia.
I think when I was thinking about that, or it brings up some like worry for me, because I was thinking what you said earlier about people wanting sometimes going for relationships that are like kind of mimic the ones that they had with their parents. And when you said that she was going to tell her partner, or she'd came up with that idea, I thought, oh my goodness, what if he ends up being like mum and he doesn't get it, or he's not very kind of like into the idea of mental health. I guess I hear that a lot from patients, like actually my partner doesn't really get it. So I'm just wondering if you've ever come across that, where actually there is a bit of exposure to telling people about these things and then it goes pretty badly, or how you would handle that.
I've not experienced a time when it has gone badly, but I have certainly experienced that feeling of, oh God, no, that guy would never get it.
Yeah.
I can think of a case where it was 2 people who got together because neither of them were very good at emotions, neither of them were very good at explaining that. They got together through the gym, and they were absolutely fine as long as it was, when are we going to the gym? Should we go to the gym? Let's go to the gym now.
Yeah.
But the minute you start talking about emotion, it was, no, that's not going to work.
Mm-hmm.
That would be where I'd say to a patient like Sharon, or as I said to that patient, do you think your partner could handle this? Do you think that makes sense of it? To which the other patient's answer was, no, he'll never get that. And that's where you have that horrible bit of thinking, well, okay, I'm not going to recommend that you should be talking to him. How about talking to X instead?
Okay.
Sister, whatever it might be, someone who shared the experience, someone who's shown care about you and has tried to get into your shell but has never managed it. So in her case, it was her sister. I think it sounds really mean of me, but there are some times when you're working with patients and you think in the session, for God's sake, just dump the bugger and everything will be so much better. And you can't say that, but you can give a little fist pump when they do it and go, brilliant, you worked it out. So the other patient I'm talking about, the one who bonded over exercise, she dumped the partner about 2 months later, and he turned out to be really quite nasty. He turned out to be a bit of a stalker.
Oh.
But from her point of view, that helped her to see he's a problem. I'm well rid of him.
Mm-hmm.
So she didn't hit the regret button that some people do sometimes when you do that. But that was a bit horrible. But you're absolutely right. You don't want to do this unless you're confident that the person they're going to talk to is somebody who's got the capacity.
Yeah.
So the reason I picked the boyfriend in that case was he'd constantly been trying to knock away into that shell. You know, he'd shown investment in the relationship, but he hadn't walked away, however much she tried to push him. And he wanted to know how she was feeling. He asked her questions about the therapy. She immediately blow up at him, but she still asked the question. That made me feel okay about that. But no, I absolutely would not believe for 1 minute that every partner would be someone I do that with.
Yeah. Okay, great. Thank you. Appreciate it.
Okay. Right. So that's, broadly speaking, the biggest of the guns that we'd use here. The counter-schematic behaviors really matter, though. So getting people to start adapting more adaptive or adopting more adaptive ways of behaving can be really powerful in ramming the point home. You know, with Jenny, remember, it was talk to your family, get on the WhatsApp group. A few months later, she was regularly going back to Ireland to see the family for the first time in 20 years, etc. She really flew with it. Last I heard of Sharon, she was doing really well. Those kind of cases can be really rewarding because you've got somebody who's had such a screwed up life for so long. They won't apply to everybody who's emotionally distressed when you first see them, but where that emotional distress has got that kind of pinning that you get to after the eating sorted. That's what we're paying attention to. And if you're thinking about how do you do that stuff around sexual abuse, emotional abuse, etc., go out there and read. There's a lot of stuff around about how to use imagery scripting that way. The book I tend to recommend in general is the Lucia Stopa book, Stopa, on the subject of working with imagery. It's a bit old now, but it's brilliantly written. And if you're worried about how to use imagery scripting with somebody with a sexual abuse history, for example, it's very good on that. Does a lot of very compassionate work. Okay.
Sorry, I have one more question, just really quickly. It was just to think, see if there's like schema work that's come as a result of like a newer trauma. So maybe it happened when they're in their adulthood. Would you still bring in their adult self at that point? Or actually are the things that you're really talking about, these core beliefs, the things that are, or the negative core beliefs that are really activated or in childhood?
No, again, if you remember, I said this relates to anything that's about experiences that felt very abrupt and uncontrollable. So, you know, this imagery scripting was first devised for veterans of the Vietnam War. You know, someone that had a bomb go off, they've been tortured, etc. We use imagery scripting. We use it a lot with refugee populations, for example, who've got a torture background that's been entirely in adulthood. So no, we'd still use it. We'd have to pick who the right person was to talk to. Sometimes it's yourself. Sometimes it's a strong family member. Depends on what the experience has been. Likewise, it's used in PTSD for just the same kind of thing. You know, rape experience. Imaginal exposure isn't working. Often because there's a lot of anger built around it, not just fear. Then it gets used there. Again, you've got to pick the right safe person. But no, this isn't just about beliefs that have been laid down when you were very young. It will work for older cases as well. Like I say, that's actually where it first got devised.
Excellent.
And it also gets used a lot in social anxiety. Jen Wild used it, for example, Chris Bruin in PTSD. It's a very widespread use technique. The one thing about eating disorders is we're a silo. We tend not to be good at absorbing stuff from outside. Part of the reason I go to the ABCP meeting most years is to steal stuff about what people are doing so well elsewhere. That's why CBT T looks a lot more like, if you like, CBT for anxiety than the Fairburn version, which doesn't look at all like that.
Yeah. Thanks.
Any other questions before I move on? Okay, well, I'm going to do one more thing before we disappear for a coffee break and then come back and talk about body image. And that's Q exposure. Now, you might never have heard of Q exposure. You might never use Q exposure, but we find maybe about 1 patient in 10 can benefit from this. And it's particularly around binge eating. It doesn't apply to other behaviors, but around binge eating. This is not a new thing. It's something we've known about for decades. it's essentially Pavlovian conditioning. But what you find is sometimes you can do getting the patient well fed. You can do getting the patient through their emotional state. And there's still the odd binge, which is down as habit. The patient will often say, I don't know why I do it, it's just habit. There's no emotional trigger you can identify. This is where the person's learned over time through Pavlovian conditioning. If you're familiar with Pavlovian conditioning, it's the thing with the bell and the food for the dog. Though we're still not sure Pavlov ever went anywhere near bells. He definitely went near food and dogs, though. And we have gut reactions, which are about food. Gut reaction, I shouldn't have called it that, really. We have reactions around food, which are biologically based, but also learning based. So, as an example, we've talked already about how to do starvation. We make sure the person's got enough food. We talked about emotional distress. Now I'm talking about exposure to food. The one thing I can't tell you how to deal with is disinhibition, because that's often about dissociation. So the person will like to binge when they're tired, for example, or it might be about alcohol use or drug use, etc. I've got colleagues who work in Canada where cannabis is legally available. And they say the problem they have is so many of their patients absolutely will not come off the cannabis, and that tends to disinhibit them, and they end up binging. And they'll say, "Oh, you can't take away from it. It's my right." Yeah, that's still getting in the way of therapy. Anyway, key thing here is exposure to the food. Now, I invite you to think about this, okay? It is Friday. In a few hours, it will be Friday evening. And on Friday evening, you might have a ritual. You might open a bottle of wine because it's Friday. You might eat popcorn because you go to the cinema because it's Friday. You might have a particular thing that you eat because it's Friday. Or you might go, do you know what? I'm too tired. My stimulus is being tired. I'm going to order a pizza. There's all kinds of things where our physical, our emotional state get tied into habit behaviors. And that's because we've learned to do that. So if you think about it, there's going to be some times when you eat particular foods. I'm fully aware there is no time in the year when I ever eat popcorn except if I'm at the cinema. So my cue there is I'm at the cinema, eat popcorn. And it feels quite odd if I haven't got popcorn there. Some people, they will have a drink while they're watching TV. For them, it feels really weird if they haven't got that there. That's just because they've grown up with that being what they do, even if it's in fairly recent years. Or, when I'm dressed in particular clothes, I'm more likely to eat, that sort of thing. So, while most of the binges we've got get dealt with by dealing with salvation, the emotional stuff, we still get occasional binges. And if they're still there, I'm not saying you need to do this for everybody by any means, but if there are these residual binges, remember there are risk factors for relapse. So we want to address them. Fortunately, it's a really quick process. So here, for example, is one of my triggers. Over here on the right, there's a restaurant menu from Mavelli restaurant here in Sheffield. I know you can't get to it, so I'm feeling pretty safe. I mean, Izzy, you might, but I'm suggesting you don't. But it's really, really good food. Really, really good Indian food. Love it. When I look at that menu, I will salivate. I have learned the cue. The menu is telling me I'm going to eat this nice food, so I start to prepare for it. Same way the bell goes and the dog starts salivating. I haven't got the food, but this cue will make me think, oh, yes, I could. Or if I smell the food, I go into the restaurant, I will salivate. So what we're going to try to do is break the connection between those cues and the experience of eating. So what I'm going to be doing here is trying to, for example, break the association between the smell of cake and binging on cake. That's broadly what I'm trying to do here. So this means that all of the digestive processes, all of the cravings I get because it's a particular day of the week, or it's a particular physical location, or it's my favorite TV show, or whatever. All of those cues, I want to be there, but not associated with eating. So in other words, going back to Pavlov, if I ring the bell and the food doesn't come, eventually the dog stops salivating. The dog learns no food. And that's what we're aiming to do with our patients. Teach them that they could be around the cue and it doesn't end up with them eating. So there's various things that you can look at on this. There's a chapter in this book on exposure therapy that we put together. But what we're aiming to do is get the person to confront the binge cue, but not to binge eat. So what this means is you sit there with the food and you just sit there and expose yourself to all the cues, but you don't actually eat it until after about 15 minutes, you find people getting really bored with it. Again, if you want to see what this looks like, if you go to the website, look at cue exposure. There's a video there that, oddly enough, quite a few of my colleagues send to their patient as a way of saying, try this, rather than actually discussing it with them. Try this. And the patients tend to come in going, that's really good. I don't feel at all like I've got any urge to overeat now. That's just me and Jess, and I'm teaching her how to literally destroy a chocolate truffle. She's really, really good at the role play there. So what I want to do is to make sure the person has normalized their eating. They're not dealing with emotional triggers. I'm teaching them about cue exposure. But what I want you to do is to sit with the food. So imagine that, for example, here I'm holding something that I would love to eat. Let's say it's a chocolate. I'd love to eat the chocolate. But what I want to do is get my patient to look at it and to smell it. And even to run their finger over it and taste their finger. And keep doing that. And keep describing it. What does it feel like? What does it taste like? What would you like to do? How's the salivation right now? Until after, how strong is the urge to eat that chocolate? And it will start out around a 10. And after about 15 minutes, it just goes down and down and down and down until the patient's going, really, do you know what? I could do without eating the chocolate. In fact, I just want to wash my hands and get rid of the chocolate. Until you've tried it, it's a hard one to imagine, but it's exactly what happened with Pavlov and his dogs. So don't be too surprised that it will work, because it does work very nicely. And we find that after one, maybe two exposures, the person sits back and goes, you know what, couldn't give a damn. Really couldn't give a damn. Yeah. So I'd urge you to try that out with the patient if they've got that particular pattern. If you're thinking, hang on a minute, that describes me in chocolate, then try it out with yourself. You won't be the first and you won't be the last, I promise you. But it's worth doing if you've got those intermittent, unexplained habit-based binges. Any questions about that one? Yep, Hannah.
Hi, Glenn. Would you do that in the session, or would you do that like in vitro, or would you get someone to do that on their own, like between sessions?
Both.
Okay.
There's nothing like ramming a point home, is there? Remember, you can explain to the patient, you can run through it with them, but it's going to be really important they practice this stuff at home. I should have said that earlier, Hannah. Sorry about that. But yeah, it's really important that they learn to do that without you being there. There's two reasons for that. One, repetition, repetition, repetition. Number two, change the context. Because what you don't want is the patient thinking, I'm okay with chocolate because Glenn's in the room. You're learning I'm okay with chocolate. And that means at some point you have to withdraw yourself as being part of the cue here. Sorry, that's the, I'm not going to try showing you that now, but it's well worth a good laugh, if nothing else. Have you watched this one yet?
No.
Yeah, I've watched that one.
And how would you describe it?
It is unusual. The situation, I find, obviously normally when you get a chocolate truffle, you would just eat it. Whereas obviously Jess in that video spends a long amount of time, describing the senses to you in that video. And I think it is quite an interesting watch, definitely. And I know Jess has said that, the session filming it was quite unusual as well for her in that situation?
Oh, absolutely unusual, because remember, exactly as Izzy's saying, the whole point about food is you eat food. And what I'm saying to you is, no, you smell the food, you touch the food, you describe the food, but you don't eat the food. And that way you'll learn that the anxiety and the urge to eat it goes down. But normally what happens is, as Izzy says, you've got chocolate, you eat the chocolate. So you never learn that the anxiety goes down. You just end up eating a lot of chocolate. Rachel, yes, go ahead.
Hiya. So yeah, with this case then, Glenn, would that be something that would be sort of planned beforehand in terms of sort of an experiment, or could a patient just sort of potentially find themselves experiencing that during the week, for example?
Well, I'd say you're not going to know whether it's a problem until you've gone through the starvation and the emotional stages. If the patient then has the problem and they discover during the week that I binge on chocolate, then you want them to bring it in and talk about it. And then you can explain what Q exposure is. I wouldn't go through this saying to everybody, this is something we must do, because it doesn't apply to most people. But where it does, it's worth picking up and spending time on.
Yeah.
That makes sense, Rachel?
Yeah, thank you.
Okay. Anyway, back to my point earlier on, which Hannah was asking about. We have to fade ourselves out the scene. So, in the days when we see all the patients in person, I do some of this work while I was in the room and the patient was in the room. And then I'd say, I'm going out of the room for a few minutes. Just keep describing those donuts, or keep describing that chocolate. Keep smelling it, etc., etc. And I'd come back and the anxiety would have gone up when I left the room, but then come down again. So the urge to eat it goes down as well. I'm hoping that makes sense enough. Like I say, it may not be something you identify in any of your patients right now, but in the future, go back, look at the video, and you'll get an idea about what to do beforehand. And it really will look a bit disgusting in terms of what happens to the chocolate if it is chocolate. I warn you now. One of the things we did when we set up the video was, okay, we're going to bring in chocolate and hand wipes. Quite a lot of hand wipes in there. Okay, so that's your big binge triggers covered. Your starvation, emotional distress, exposure and availability. And as much as possible, you want the patient minimizing things like alcohol, etc., because that can be a problem in itself. What I want to do is I want to work on body image with you. It's now 10:02. Should we take a break and meet again at 10 past? Is that okay? And then we'll just use the rest of the time to talk about body image and just finish off with how we end therapy. Okay? So I'll see you in 20 minutes, folks. I'll just turn off the recording as I'm going.